Welcome everyone to this week's BRAINCAST. My name is Pospo and I am happy. Why are you happy, Pospo, you would ask? Well, it's mid-September and the sun decided to make its glorious appearance once again up in the London skies. 26 degrees, can you believe it? I can't. Enough though with my weather forecast. Last week we welcomed Dr. Ahmed Hankir, widely known as the wounded healer. We talked about being a psychiatrist with living experience of a mental health disorder. We talked about Islamophobia and the origins of hummus. Yes, it is from Lebanon, but it's delicious regardless of where it comes from. My guest this week was a pain to find. I had to cross a whole road and go across at a mostly outpatient department where his office is. Actually, I didn't even have to cross any road. I just dropped him an email. Dr. David Okai, he's the clinical lead for the mostly neuropsychiatry department, a honorary senior clinical lecturer in neurosciences in Oxford. He has been an advisor to the all-party parliamentary group on the management of the neuropsychiatry of Parkinsons. He worked on the clinical advisory panel of Parkinsons UK and serves on the board of directors for the British Neuropsychiatric Association. To be honest, he has a really wide range of research interests, from Parkinson's disease progression and how this impacts on personality and behavior to depression and traumatic brain injury. However, it is work on impulse control disorders that we will focus on today. David, welcome and thank you for joining me.
Thanks very much, Pospo, and thanks for inviting me.
Fantastic. So David, let's start with the basics. So impulse. The first thing that comes to my mind is a fragrance from the 80s, but we're certainly not going to talk about this. So what is an impulse control behavior? And at what point does it become an issue?
Yeah, so that's an excellent question. And I think it's got implications for the whole of psychiatry, really. Impulse control disorders are referred to as a group of disorders where the problem is a failure to resist an impulse or temptation to perform an act. That act is genuinely harmful for the individual concerned. So, and this does relate to the whole of psychiatry. Psychiatry, in my mind, is actually a relatively easy specialty. It doesn't matter what the syndrome is. It doesn't matter how you present or what idiosyncrasies the person has. Really, psychiatrists become involved when the behaviors reach threshold for caseness for disorder. So that means that they impact on your social or occupational functioning. And so that's in relation to impulse control disorders, that really is the question. Are these things that you're doing that are repetitive and difficult to stop, are they causing harm to your relationships, or are they causing harm to your ability to work or interact with others?
And I mean, it's interesting. You mentioned, that they're repetitive and that they are really hard to stop and resist. So how is this different from a compulsion?
Yes, so again, that's a great question. It's a big debate. The obsessive compulsive disorder spectrum have had debates about where they should lie in terms of DSM-5 categorization, for instance, and similarly so for the impulse control disorders. What I'd say is that they share some features, as you say, of this inability to refrain from repetitive acts when presented with the choice of immediate reinforcement despite long-term negative consequences. But the key difference between the two really is the function of those repetitive acts. So, for example, in OCD, the behaviors are usually driven by an effort to avoid anxiety, whereas the behavioral addiction, so the impulse control disorders, that is driven by the pursuit of pleasure, arousal, or gratification. There's a famous, sort of CBT therapist within the Maudsley who likened a contrast between the two of them as a push versus a pull effect, with compulsions denoting coercion from discomfort and addictions indicating an attraction from something. So in many ways they share similarities to substance misuse disorders. I'm going to say that is in some ways, of course, a bit simplistic, because even with, for example, alcohol, you can have both positive and negative reinforcers. So, for example, those who are severe alcohol dependent individuals, they will drink not only to avoid with the withdrawal syndromes, which would be a negative reinforcer, but they'll also drink presumably because of the habit / sort of slightly more pleasurable components of the condition. So it's a complex entity in its own right. But on the whole, they're felt to be different from OCD. What I would say is the ICD-5, DSM-5 has brought them together for the first time into a single category of what's called behavioural addictions, because there's so much of a wealth of evidence behind the pathological gambling as a behavioural addiction, slightly separate from the substance misuse problems. But they say at the moment, sexual activity, exercise, shopping doesn't yet have that same body of evidence to put them in that category yet.
I mean, I'm pretty sure it's not as straightforward as the question might imply. But what part of the brain is mostly related to the impulse control behavior and how we respond to them?
Yeah, so that's a really good question. And I think this is one of the most exciting things about the impulse control disorders. And that is that we've been able to replicate on quite a large number of instances that this is related to an area of the brain known as the ventral striatum, which is part of the frontal section of the brain. And even more exciting than that is that Parkinson's is a bit unique in that usually, for most conditions, you don't really know what's going on in other sections of the brain, especially in the deep down sections of the brain. But because of something called subthalamic or deep brain stimulation, whilst that is designed to try and stimulate the electrical proportion of the small, sort of the small midbrain, which helps with the movement of these patients with Parkinson's who have movement problems, it also allows us to record activity in those areas. And being able to record activity in those areas while simultaneously recording activity on the outside bits of the brain. And we've seen that there's a clear link between the frequencies between what a part of the inner brain called the subthalamic nucleus, and actually that relationship between the subthalamic nucleus channels and their corresponding EEG channels shows that there is a link both with patients with dyskinesia, those wriggling, jerking, weaving movements, which may be an overactivity of the motor circuits, and there's a link between the more ventral aspect of the subthalamic nucleus and the ventral part of the brain, as I said before, which may show a link between the more volitional or wanting parts of the brain. So really what that seems to show is that there's an underlying role of the subthalamic nucleus in suppressing unwanted or inadequate behaviors or movements. So it's behavior or movement, which I think was fascinating. Will of movement, or its will of the entirety of the psyche as well.
I mean, judging from my life course and my decision-making process, my subthalamic nucleus then must be a bit, So I can already think, David, of a few psychiatric disorders that may present with issues around impulsivity, from addictions, as you mentioned already, to personality disorders. And in fact, in a paper from a few years back at the American Journal of Psychiatry, so John Brown found that impulse control disorders were really common among psychiatric inpatients. So are they then just a symptom or a separate disorder altogether?
Yeah, I think, again, it's a fascinating question, Pospo. And I think what we're really looking at is a need for a drive away from the current nosology, the current diagnostic criteria, to a situation where actually diagnoses, behaviors, are fueled by the underlying neuroscience. And so we know of Jasper's sort of hierarchy of diagnosis, and that's been incredibly important in managing people in a general sense and in improving our knowledge. But now with the wealth of evidence base behind the neuroscience, we do have to move to features of behavior that can be understood by way of neuropsychological paradigms, by way of imaging paradigms, by way of behavioral paradigms, all the things that might cluster a group of behaviors together. If your brain lights up in a certain way, and you have a certain type of behavior, and then there's some neuropsychological correlates, neurobehavioral correlates, neurocognitive correlates, and then we should be moving in the group and saying that the brain, while it's limited in the way that it expresses behaviors, is suggesting that these things are related. So, I mean, I think what we probably need to look at is a broad concept of what is essentially a disinhibitory psychopathology, for want of a better word at the moment, and see which of the existing diagnostic categories best fit into that concept of a disinhibitory problem, and then see how they're similar and how they're different, as opposed to the way that things are done at the moment, which is this is historically how things have been, and therefore this is how things are going to be.
I mean, you are mostly interested though in a specific subset of the impulse control disorders, so the ones linked to Parkinson's. So tell me more about it, as it seems that it's not one thing, right? So what are the different subtypes that one would expect?
Yes. So the history behind this is 20 years ago, a group at Queen Square noticed that there were a range of behaviours that some of their Parkinson's patients started to talk about. And if you were doing a multiple choice questionnaire as a medical student at the time, and someone said there's a link between dopamine, the medications for Parkinson's and gambling, you probably would have said false, and you would have been fairly sure in your answer. But of course, when you think about it on a different level, the medications that are used for Parkinson's may well stimulate dopamine, which is known to be associated with reward. So in that regard, there are a range of behaviours that have been recognised in the context of Parkinson's with a degree of consistency, somewhere in the realms of 20% of patients. And those are pathological gambling, hypersexuality, compulsive shopping, and compulsive eating. And so the first two, the pathological gambling and the compulsive shopping, those two in particular, seem to be related to learned rewards, whereas the hypersexuality and the compulsive eating seem to be more natural or innate rewards. But there are a range of other behaviours, which is why I was speaking before about this idea of a disinhibitory psychopathology, where people start to feel compelled to repeat simple tasks, either taking, sort of putting things in order, taking things out of order, dismantling, sort of washing machines, and then putting them back together, sometimes well and sometimes badly, or more complex tasks, such as going out and spending, sort of 7 hours in the garden until your spouse tells you to come back in. So those are repetitive behaviours. The one that's simple behaviours, they're known as punding for various reasons. And the more complex behaviours, they're known as hobbyism. So what we're looking at is either problems such as gambling, shopping, eating, and hypersexuality, or repetitive behaviours such as which are either simple or complex. Additionally, there's a final group of related conditions where a proportion of patients feel compelled to increase their medication above the dose prescribed by their physician, or take more of the medication than they should be doing as prescribed. And those have been known as dopamine dysregulation syndrome patients in the past, although our group prefers the term off-period dysphoria for a range of reasons. We think that the reason why people are doing this is because they start to become worried about coming off. They're more likely to have motor fluctuations or movement fluctuations, so they take more of their medication in a worry that they might come off, that some of their features may be heading signs of coming off.
That's really helpful. But you already hinted about the link, between the medication for Parkinson's and the impulse control disorders. But let's leave the medication aside for a bit, as I would like to touch on them a bit later. So, from the Parkinson's patients, forget about medication. Who are more prone to develop impulse control disorders? Do we know? Are there any personality traits? Anything else?
Yeah, I mean, this is an exciting emerging field, and I encourage anyone who has an interest to look into this type of thing. There are a few things that are now very well established because we have large cohorts of patients that we've been able to look at these things with, including our cohort from Oxford, which was of 1,000 patients. But on the whole, those, if you're single, if you're male, if you're young, those have been reliably shown to be at increased risk of impulse control disorders as well. Interestingly enough, if you have a current or former history of smoking, that again, it shows that you're likely to develop one of those problems, which may suggest, to answer your question, a pre-morbid vulnerability to this range of addictive or prone behaviours. Then there are other factors. We mentioned medication, and there are subtypes of medication, but we can talk more about that a bit later if you wish.
Yeah.
And then there are actually some neuropsychiatric associations as well. So depression is more common in those with Parkinson's patients with impulse control disorders than those without. And that it remains unclear whether that's because depression is a risk factor for ICDs, whether it occurs as an attempt to, whether ICDs occur as an attempt to try and treat your depression. So you're feeling depressed, so you go out and you buy yourself lots of clothes, for instance.
Yeah.
Or whether depression occurs as a consequence of the impact of the impulse control disorders as well. What I would say is depression is associated with so many other neuropsychiatric conditions that it is more likely to be, sort of a correlated factor of neuropsychiatry in the context of a significant biological component to it as well. And then apathy, which is surprising because you've got individuals who may go out and gamble, their entire families, sort of household of money away, for instance, and that doesn't seem to fit with apathy. But actually, it's been found to be associated, and perhaps again, maybe it's something about a pseudo apathy, where individuals, pay less interest to all other rewarding efforts apart from current one, or it may be biologically mediated as well. I think it probably is a combination of the two, but that's an exciting area to look at in more detail.
I mean, there was a recent case report on the Journal of Movement Disorders. So they were describing impulse control disorders in a young patient with FBOX only protein 7, which is a rare genetic cause of autosomal recessive juvenile Parkinson's. So are there any genetic underpinnings for impulse control disorders?
Yes. So, I mean, it seems that there are. I mean, there's a really intriguing study by Kramer and colleagues who found that if they combined a range of recognized genetic vulnerabilities to addictive behaviors, so they were looking more at the dopaminergic and some serotonergic dopamine signaling and metabolism-based genetic linkage variables, that they were able to predict the heritability of a prospective cohort of Parkinson's patients up to an extent of 57%.
Wow.
So I think that's pretty interesting. I think that we do need to recognize that this is still an emerging area, and it's been limited to a degree by the way that people have screened for the behaviors, have asked about the behaviors. They're not, these behaviors aren't a dichotomous measure. They're not a yes, no. Do you eat, has your change in preference for food changed? Are you eating more sweet things? It's on the spectrum. So that's probably limited some studies today, but now there's more of a consensus on recognized severity scales, which mean that we can understand this factor some more. As I said before, a lot of those genetic studies implicate dopamine and serotonin as well, alongside other transmitters such as norepinephrine, glutamates, and opiates to a degree. But this is really a very preliminary sort of data. The studies on the whole tend to get barely powered to pick up a huge amount of differences. So again, one to watch for the future.
I mean,
the only other thing I would say there is, of course, the interesting factor. Sorry, the interesting factor of male patients are likely to develop some behaviours, and females will be likely to develop other behaviours. So men are more likely to develop gambling, women more likely to develop compulsive shopping, for instance, and that types of things need to be looked at, whether or not there's a X-linked chromosome or some other related risk factor. Sorry for interrupting you, Pospo.
My pleasure. So, David, you recently co-authored the papers, and congratulations. I mean, it was published in a massive journal on Brain. So in there you describe a pupillary reward sensitivity measure that can, in fact, differentiate between Parkinson's patients with and without impulse control disorders. Tell us a bit more.
Yeah, we were quite pleased with this publication. I think the main reason why it's such a the main reason why is because it's something I sort of talk about a lot, which is a need for neurologists and psychiatrists or neuropsychiatrists or even or psychiatrists in general to work more closely together. And I was previously in Oxford, which really promoted the idea of working together. It wasn't this sense of, you come along and give a bit of advice to someone on the neurology ward and then leave. The model was of being really integrated into the neurology teams, and King's does a great job of that. And we're keen to expand it even more here within the Maudsley as time goes on, as you know, Pospo. But this was a large cohort of patients with Parkinson's disease and RBD, REM, sleep behavior disorder, who were followed up over several years. And it was a large cohort, almost 1,000 patients, which allowed for some interesting tests and some meaningful results as well. And so in this study, we used sort of infrared eye tracking to measure eye position and pupil diameter. And we asked patients to shift their gaze to a visual target as quickly as possible in order to obtain a monetary reward. And the reward was either no P, 10p, or 50p. And the reward incentive offered varied over trials as well. And we looked at the effort the patients were putting in by looking at their saccadic velocity. So that's the speed that their eye moves in the direction of the reward, but also the diameter of their pupils. So that's how much their pupils dilated in relation to this wonderful 50p that they might get over time. And what we found was individuals with impulse control disorders showed heightened sensitivity to monetary rewards, but being off medications overnight didn't change the reward sensitivity in the impulse control disorder group, but it did for the control group, where they became less responsive to rewards over time. But there wasn't any difference in reward sensitivity when the patients were on. So when they were taking their Parkinson's medication, on is when all your medications work and your movement function is very, very good, whereas off is when your medications have started to run out and you become stiff, slow, shaky, or low. And so that difference in the speed of the movement and the pupil dilatation provides us a means to differentiate using a physical measure Parkinson's patients with impulse control disorders from those who don't experience them. But even more interesting than that, Pospo, in the control group, those who showed strong saccadic eye movements and those who had lots of pupil dilatation, those were, because it was a follow-up study, it was a prospective study of 1,000 patients, those were more likely to go on and develop impulse control disorders as well. So this is incredibly exciting because it gives us a sense of a biomarker to the development of this range of condition as well. It's something that I keep banging on about, but really in my mind, there's no difference between movement, whether it's physical movement or psychic phenomena that relate to impulsivity. So if your tendency to move quick, or you have a range of movement disorders that show that the cap has come off your control of your movement, you'll always need to look for whether there's the psychic equivalent of that. In other words, do they have psychic disinhibition? Do they have psychic apathy? So movement, motor disinhibition, motor apathy, almost or commonly correlates with psychic apathy or disinhibition.
Wow, that's really interesting. I mean, let's go back to the medication aspect. So in 2006, a Weintraub showed an association between dopamine agonist use with impulse control disorders in Parkinson's disease. So he followed that up in 2010. So he looked into more than 3,000 patients with Parkinson's. So he did find that dopamine agonist treatment in Parkinson's disorder is associated with 2 to up to 3.5-fold increased odds of having an impulse control disorder. And I have to say that things escalated pretty quickly. And in 2014, a paper in JAMA Internal Medicine, they looked into millions of drug adverse event reports. And they urged, in fact, the FDA to have boxed warnings as part of the prescribing information for dopamine agonists. So where's the truth?
So I think if you think about the underlying neuroscience behind this, so there are different dopaminergic pathways in the brain, and the dopamine agonists or levodopa, there are two different types of medications. Dopamine agonists tend to be used in the earlier stages of Parkinson's and seem to be tolerated slightly better in the earlier stage of Parkinson's than levodopa. That's a bit contentious, but on the whole, that's the current thinking. The underlying neuroscience is the dopamine that you use to treat the motor deficit. So the dopamine you give to treat the movement symptoms works. However, there's a differential degradation in this progressive neurodegenerative disorder. So you'll have a decline in your dopamine receptors in different parts of the brain at different times. So whilst it's clear that, but from the substantia nigra, that you have neuronal death at that time, and usually you need 60 to 70% neuronal death before you even start to see any of these effects, which is part of the reason why Alzheimer's trials struggle so much, because by the time people start to realize memory, it's a bit late. But the reward pathways are probably still relatively intact when you start to see the movement symptoms. Those are different pathways. They're in different parts of the brain and they have different connections to the movement symptoms.
Okay.
Therefore, when you give them these dopaminergic medications, whilst you're treating the movement symptoms, the same level of dopamine may result in a relative overdose of reward-based circuitry. And that's probably how we see this phenomenon of impulse control disorders as well.
So let's get a bit clinical then. So you have someone that presents with impulse control disorders and has Parkinson's. So what do we do?
Yes. So the first thing I would say is prevention is the best treatment. So really, there's an onus on neurologists, Parkinson's specialists, neuropsychiatrists to sort of educate everyone about this phenomena that is impulse control disorders, especially in this day and age. I think in the earlier stages, you could get away with not mentioning this because it wasn't well known, but everyone should know about this. So if they notice any of these behaviors, they need to stop taking them and notify people individually. The next approach is a reduction or discontinuation in the dopamine agonist if they're on one. Again, remember I said that's different from levodopa. And then if possible, a reduction in levodopa as well if the behaviors aren't controlled. What I'd say is two things. That should be done slowly. Usually from the 5 studies that have looked at this, the remission rates are reasonably similar with a mean improvement of 74% of cases. That still leaves a significant proportion of patients who need something else. Either they can't tolerate the reduction or they'll need something like cognitive behavioral therapy as well.
So David, you've been telling me all this time, I know I'm oversimplifying this, okay? But you've been telling me that a tablet can actually change your behavior. So the final question, for the £2 million, you're not going to get any pounds. So are impulse control disorders the final nail on the coffin for the mind-body dualism supporters?
So I view being asked that question as a milestone in my career, Pospo.
Go for it.
But I want you to think about what we've been discussing. So you take a tablet and that changes your behaviors. It may render you liable to gamble away your family's household, their estate. It may mean that you gain weight because you start to eat and can't stop eating. That's got massive implications for free will, and it's got implications for our research into the underlying vulnerability factors, because not all patients get this. It's got implications for our diagnostic constructs as well. It's got implications, as I said before, for movement, even if that's pupil dilatation or movement in the context of a tremor and our behavior. So what it shows is these are all so intrinsically linked that there's no sense trying to divide them. That's just a historical phenomena, which is probably been deleterious to our patients, and we need to fight strongly to stop it.
That was David Okai, BRAINCAST people. Thank you so much, David. I'm pretty confident that people will be hearing from you in the years to come. And from one impulse to another impulse. So next Monday, we're welcoming a man with more titles than Real Madrid, Professor David Nutt, the president of the European Brain Council. We will talk about repurposing drugs that are currently labeled as illegal, but for a good purpose, for treatment of mental health disorders. Think about MDMA, think about psychedelics, think about don't think too much. Pospo and BRAINCAST for more learning, over and out.
All best. Bye-bye.